So thank you and welcome. We are pleased to be here speaking with you today, and we have representation from AOTA, ASHA, and APTA. We will be speaking about models of payment and rehabilitation and the use of a cross-disciplinary comparison. So the voice that you hear presently is Renee Kinder. I currently serve as Executive Vice President of Clinical Services for Broad River Rehab. I am pleased to be joined by Sharmila Sandhu, JD, who is Vice President of Regulatory Affairs with the American Occupational Therapy Association, and Kate Gilliard, also JD, who is Director of Health Policy and Payment with the American Physical Therapy Association. We are going to be walking you through today a variety of different payment models. We're going to begin with discussion on the Medicare physician fee schedule, and I have 5 different areas that I'm going to highlight. We'll begin with an overview, then go into 2022 updates. From there, go into history and background, code structure, and coding considerations. So what do you need to know about the Medicare physician fee schedule? To begin, it's updated yearly, generally around Halloween at the end of October. In 2021, it was released on November the 2nd. It is released by the Center for Medicare and Medicaid Services. And this is important to keep in mind because the group that releases the information is a little bit different from the group who develops the code structure, okay? So multiple different entities here. The Medicare physician fee schedule as well has physician in the terminology, but it applies to a variety of care providers, namely your physical therapist, your occupational therapist, and your speech language pathologist for purposes of today's discussion. And when we consider the care setting where this is billed, this is going to be for services provided in all Medicare Part B outpatient therapy settings, except for those provided in a critical access hospital. Let's move on now to what some of the updates were that you've likely heard about from the 2022 changes. There were updates to the conversion factor. This is pretty standard. You should look for this to occur generally every year. There were updates to KX and medical record thresholds for calendar year 2022. There were updates to the assistant payments. There were updates for telehealth therapy codes, and this is going to be separate from conversations that you hear tied to the public health emergency. So you have rules and then you have allowances from the PHE. So also something to keep in mind. There were updates to supervision requirements of assistants and new codes that are allowable for therapists, including the remote therapeutic monitoring codes. We'll move on now to a bit of history and background. So you'll notice that the updates that I described on the last slide say calendar year. That's going to be different from some of your fiscal year changes that occur in the tax spectrum. So keep those timelines in mind as well. So what is the history and background on Medicare physician fee schedule? How are codes created? Who is involved? And it's important to recognize that the codes that all of the therapists across the nation have access to are present and valued secondary to the due diligence of your therapy associations. So the individuals at ASHA, AOTA, and APTA advocate for how the codes are structured, defined, and valued, and it takes a significant amount of time for a new code to be created. This began in 1992 with Medicare payment being under the physician fee schedule for services for physicians and, as noted, other billing professionals. This is also true for many diagnostic tests, a number of other limited services under physician fee schedule. There may be separate payment for the professional and technical component, and we will move now into a bit on code structure to talk about how that is broken down. So the physician fee schedule is what you see in published rule. But in the background, there's a process through the American Medical Association, through really 2 different divisions or two different sets of meetings and entities. We have the CPT process and we have the RUC process. It is through the CPT process that codes are defined. It is through the RUC process that codes are valued. And when codes are valued, there are multiple different components for each procedure. That is going to include the professional component. If I were to simplify that, that's the work, okay? That's the work as expressed in an amount of time, technical skill, physical effort, stress, and judgment for the procedure required of physicians and other practitioners or QHPs. There is a technical component. The technical component is practice expense expressed in overhead costs, such as assistant time, equipment, supplies, etc. And then the final piece is the professional liability component. So through this process, with the American Medical Association and the CPT and the RUC, all of these areas are discussed, they are defined, and then it is CMS that produces what we see in the Medicare Physician Fee Schedule rule. And I will close this section with what are some key areas that you need to consider in billing and coding. So the first is that generally there's going to be a standard 20% copay, right? So you see what's published, but we know that generally payers are going to pay around 80%. There's either going to be a 20% out of pocket or a co-insurance payment that comes for that final 20 to the individual who is receiving the services. There are also rules around non-participating status and limited charge. There are different rules for facility and non-facility rate. Depending on where you live in the nation, there are going to be geographic adjustments, and depending on the number of codes that you bill in a day, there are considerations around something known as MPPR or multiple procedure payment reduction.
Thank you, Renee. Again, my name is Sharmila Sandhu. I am Vice President of Regulatory Affairs at AOTA, and I'm going to talk to you today about payment models in the post-acute care settings. And these are all prospective payment systems, which are paid in a different way, typically in a bundled type of payment to the facility that we will be speaking of. Post-acute care payments typically apply in the skilled nursing facility setting, in the home health agency setting, the inpatient rehab hospital facility setting, and long-term care hospital settings. So I'm going to start by talking to you about some major changes that have happened in the last several years. And you may have heard of many of these. I know that they're part of the agenda for today, some of these issues. So the first is the patient-driven payment model, or PDPM, which is referring to a new payment model that was put into place in skilled nursing facilities starting in 2019. This model was driven by a concern, in part a concern about fraud and abuse under the RUGS 4 system, the previous payment model, where payment was based on the amount of therapy minutes in a category. And there were many reports and MedPAC recommendations leading to recommendations to CMS and Congress to develop models like this. It took several years to develop PDPM prior to 2019. AOTA, APTA, and ASHA were all represented on technical expert panels and submitted comments throughout the process. PDPM, it uses patient characteristics and a patient's functional level to determine a payment category. You will see here there are various components that contribute to the daily rate for a skilled nursing facility stay. And you can see that occupational therapy, physical therapy, and speech-language pathology are only a few of the components that are part of that rate, including, that also include nursing, non-case mix, and non-therapy ancillary services. I wanted to also talk under PDPM about a few of our advocacy successes that all three of our organizations have worked very closely over the years to achieve in monitoring PDPM, and I'll get to PDGM as well. But in PDPM, we had advocated for a combined 25% limit on group and concurrent therapy to ensure that practitioners are able to use all three modes of therapy and still ensure that patients can receive one-on-one individual therapy when it is indicated. We also advocated for the tracking of utilization for skilled therapy services in the minimum data set or MDS assessment tool, specifically in section O, which ensures that CMS can track the use of therapy and also help determine where audits may be specifically needed at specific facilities. I also just wanted to point out in this slide that the MDS is completed at admission of the patient. Now the volume of therapy services provided no longer determines payment. Instead, the primary diagnosis and functional status determines therapy payment. You may see here that there are self-care items and 7 mobility items that are used as part of section GG of the MDS to assess functional level. Section GG has been a large focus for therapy practitioners in considering that functional level and how it fits into the payment model. Next slide. And now I'm going to turn to the patient-driven groupings model. So similarly, under the patient-driven groupings model, which applies to home health agency settings, a new payment model went to effect in January of 2020 for similar reasons that I explained for Pdpm. CMS wanted to adequately reimburse for complex care. In addition, there were MedPAC reports. MedPAC did not support basing payment on the number of therapy visits in home health agencies and had a series of report and recommendations to CMS to instead base payment on patient clinical characteristics and diagnoses. So in addition, CMS considers many different aspects. One, they again are looking at functional level, as you can see in the slide. The admission source and the timing. So was the admission from an institution or from the community? The episode timing, was it early within the first 30 days or later in the episode, or separate episode? Comorbidities, were there other conditions involved for that patient admission? And they scale it as there were no comorbidities being 0, low number of comorbidities being 1, and high would be 2 or more. And then you should note that there are 432 possible case mix adjusted payment groups under PDGM. So it's really important to accurately document patient characteristics in home health agency care. So, and then this slide similarly under PDGM, I just wanted to note that principal diagnosis again provides information to describe the primary reason for patients receiving home health services. Patients are put into one of 12 clinical groups based on their primary diagnosis, and PDGM designates a functional impairment level for each of 30-day periods based on the OASIS assessment items for self-care and mobility. The functional levels include low, medium, or high, and the scoring varies per item. Remember again that these 432 possible payment groups require accurate diagnoses so that the agency receives the appropriate payment and the patients receive the care that they require to access therapy services. I just anecdotally wanted to say that based on our feedback from therapists and therapy assistants, we have heard concerns that therapists and assistants are being asked to provide less therapy than they believe is clinically appropriate under these models. Overwhelmingly, that's been the majority that we've heard of from AOTA. However, I do want to also say that there have been a vocal and maybe smaller minority that believe that Pdpm and PDGM in some cases have given them a more autonomy and the ability in their facilities to provide, use their clinical judgment to provide the services they need. Next slide. So in addition, I just wanted to cover a new unified post-acute care payment exploration that has been happening as required by the IMPACT Act, a law that went into effect at the end of 2014, if I'm not mistaken, that requires a look at additional payment reform in the post-acute care settings that I mentioned. This is also based on MedPAC Commission recommendations. And again, there have been technical expert panels meeting for several years. They met in 2018, 2019, and 2021. Each of our 3 organizations has been represented at the TEP tables. AOTA was represented by Dr. Natalie Leland. And that work is ongoing. We continue to meet and talk about a new payment model, and we all are sort of waiting with bated breath for a report that is to come to Congress to look at a prototype for a PAC payment system. We have a number of concerns because we believe that the settings are intended to distinguish patients based on different patient characteristics. And so we will need to see what that looks like. Changes cannot be implemented unless Congress passes new legislation. So we're all looking for that unified post-acute care payment model. I wanted to note that AOTA and APTA commissioned a joint study in 2019, basically through 2021. We were looking at outcomes, knowing that Pdpm went into place, knowing that PDGM went into place. We wanted to really get a sense of what is that right care for the right patient at the right time, and think about outcomes in these settings to support the provision of therapy services in post-acute care. And so we undertook a study with Dobson DeVanzo and Associates looking at the functional ability of patients and really the ability to reduce readmissions in acute care. And those findings are that therapy reduced readmissions. Looked at 1.4 million Medicare cases from CMS data, and there are implications for the ongoing reforms that we've talked about, as well as development of any future reforms. We believe that we have data, and that data from Pdpm and PDGM should be looked at as well to incorporate, because this data was pre-Pdpm and PDGM looking at outcomes. And finally, I just wanted to talk about future post-acute care needs for access to therapy. We believe that accurate, complete, and timely documentation of therapy services needs to connect patients with the goals and outcomes. Collection of meaningful standardized assessment data is going to be critical in the future. Use of data to inform and drive practice, and best practice models, practice guidelines, and evidence-informed practice is part of the future. And finally, recognition of our full scopes of practice for all of our therapy disciplines will be critical as we move into these settings.
All right, thanks, Sharmila. So while payment models themselves are hard enough to wrap your head around, the healthcare industry is also constantly taking on new approaches to quality and value, which just add another layer of complexity to the mix. So I'm going to give a brief overview of these models and how they're integrated into the models Renee and Sharmila just described. So CMS and private payers are constantly seeking to encourage smarter spending on healthcare. And in order to do that, payers have to look at not only the volume of services delivered, but also the value of those services when determining payment. So keep in mind here that value is a clearly defined term. It means the quality of a service measured by patient outcomes divided by the cost. So not every service that delivers better outcomes, nor is every service that lowers costs necessarily considered valuable. It's the balance of the two that payers are really looking to achieve. So there's lots of different ideas on how value can be incentivized, but there are certain approaches that are becoming more and more common. Now, it's generally understood that there's about 4 types of payment models broadly. First is just fee for service. It's what we see in the physician fee schedule. It just doesn't get any simpler than that. The second is fee for service with a link to quality. And this is by far the most accessible form of quality payment models for most providers. It allows them to bill services as normal under a fee for service model, but then there's an additional incentive or disincentive for some additional reporting. Now, the extra reporting can be burdensome. It's not always worth the cost to participate. But also keep in mind that there's multiple types of category 2 models. Some of them just pay for reporting, but some others actually pay for performance. Category 3 uses a fee for service architecture, but it really puts providers at risk for overages or allows them to share in savings. Category 4 is sort of the ultimate population-based model where per member per month or global budgets are used to pay for services of an entire population. So most of the action right now is really happening in category 2, but expect more and more programs to sort of drift over into category 3 and 4 in the near future. So let's talk about some real examples. First is Mips. Most of you probably already have heard about Mips. I hope so. It's by far the largest quality program that therapists are able to participate in. It's a Category 2 pay for performance model where clinicians are paid under the fee schedule as usual, but they submit data on specific measures grouped into 4 categories: cost, quality, promoting interoperability, and improvement activities. So at the end of the performance year, a clinician is scored on those measures and receives a bonus or penalty to their payments 2 years later. So while this program represents a major step forward in getting just the rank and file clinicians to participate in a Medicare quality program, there are some serious flaws with Mips. For example, while the program's intended to offer up a plus or minus 9% increase or decrease in payment adjustments, I should say, the program has actually never awarded anyone more than 2% increase. But this program is extremely burdensome to participate in. So for a lot of providers, this 2% adjustment is just not worth the burden it takes to participate. The program is also flawed in the fact that non-physician providers cannot report a lot of these measures. For example, for therapists, we are only able to report on quality and improvement activities, not cost or promoting interoperability. So by leaving so many providers out of the cost calculation, especially, it's an issue because cost is such an essential component of the value equation. Now, shifting to post-acute care, we have more Category 2 payment models. Again, that's a fee-for-service system with a link to quality. So in the quality reporting programs, or QRPs, which are active in both home health and SNFs, we see an example of pay for reporting. SNFs and home health agencies are required to report certain data, and failure to do so results in a 2% penalty to payment. Now, neither of these programs actually impose incentives or penalties on providers based on the actual results of the measures they submit. However, this quality data is made public as a way for consumers to potentially judge the value of a provider. Now, on the other hand, both home health and SNFs have other programs which do in fact score and reward them based on their performance. The SNF value-based purchasing program has been active since 2017, and it scores facilities based on a single measure: hospital readmissions. SNFs are ranked based on their score and are awarded incentive payments accordingly. So the most recent SNF rule actually had CMS indicating that they're considering adding more measures to this program. But in home health, agencies are going to be subject to a plus or minus 5% payment adjustment based on 12 measures, including 5 OASIS measures, 2 claims-based measures, and 5 components of the HHCAP survey-based measure. So the home health value-based purchasing model is going to go nationwide in 2023, but it's actually been in operation as a CMMI model since 2016 in about 9 states, of which you can see them there. So the CMMI model between 2016 and 2019 actually saved Medicare $604 million. So there is quite a lot of excitement about how much money this could potentially save once it's rolled out nationwide. Now, speaking of CMMI, new models are constantly being developed and implemented across healthcare, and CMMI pretty much holds the primary responsibility for developing these new models. And it's really interesting to note that recently CMMI has stated one of their aims is to have all or the vast majority of Medicare fee-for-service enrollees in a care relationship with accountability for quality and total cost of care by 2030. So whatever model or program you're currently working in, don't get comfortable. There's definitely a lot more change on the way. And I'm sure we are going to see more and more of these models drift over into Category 3 and Category 4 as we make our way there. So we look forward to taking your questions in the Q&A.